Okay, ladies and gentlemen, it's 7 o'clock. Following the resignation of Councillor Lawman as chair, it falls upon me to open the meeting of the Health Scrutiny Committee tonight. Before we get into electing the new chair, there's been a request to change the running order, and hopefully this is right, for the reports. We're going to start with item 7, which is health integration, and then essentially run back from items 10, 9, 8 and 6. If that's okay. Is everybody okay with that? Great. In which case, let's move on to the first item on the agenda, which is the election of a new chair. Can I ask, are there any nominations? Councillor McGee.
Thank you. I'd like to nominate Councillor Anne Lee, please.
Okay, and do you have a seconder? I'd like to second Councillor Lee if I can. Is that all right? Okay. Any other nominations, please? Councillor Brown.
I'd like to nominate Councillor King-Lawal, please.
Okay, and you have a seconder?
Absolute abhorrentness of how someone who has been so brazen with their views thinks that they can chair a health committee.
Sorry, Councillor McGee, please.
If this goes through, Chair, consider that my resignation from this panel. I refuse to sit on a panel chaired by a big...
Thank you. Sorry.
Yes, I'd like to second it, thank you.
Okay, thank you. Any other nominations? Okay, can I have votes, please, for Councillor Lee?
That's three, Chair.
Yep. And can I have votes, please, for Councillor Lawal? 4.
Well, I'm glad I'm on...
I think that makes the new chair, Councillor Lawal.
Thank you, everyone. It's a privilege to be voted in as chair of this most esteemed committee. Should we move on with the agenda? Right. Apologies for absence. Do you have any apologies?
Yeah, we've received apologies for Councillors Maxwell and Councillor Carr.
Thank you.
And Councillor Ty as well.
Councillor Ty. Right.
Councillor Lawal, sorry to interrupt, but I noted that there was a councillor who was a reserve councillor on this, and whether you wanted to do a minute's silence prior to the committee formally commencing.
Yes.
That's Councillor Mike Tebbett. He was the reserve member for this committee.
That's a good idea. Yeah. Shall we do that now? Yeah. Thank you. Thank you for that. The next item on the agenda is the members' declaration of interest. Does any members have any interest to declare? Councillor Lawman.
These are actually all on the website, but for the purpose of clarity, I'll do. I'm a public governor for Kettering General Hospital, and when it comes to item 9, EMAS and the item 7, there's mention of community transport and patient transport, and I'm a director of Shire Community Services who perform both those functions. They're both personal interests at this stage.
Superb. Thank you, Councillor Lorman. Any other members' declaration of interest? No. Okay, the next item on the agenda is notifications of requests to address the meeting. I'm not sure exactly any notifications, no. Okay. Okay, the next item on the agenda, meetings held on, minutes of the meetings held on the 14th of November. Are we okay to ratify that? Yep. Propose. Of a seconder?
I wasn't there, so I can't.
Yep, superb. Thank you, Councillor Best. The next item on the agenda is the update on Kettering General Hospital rebuild. Is that, we've changed the structure, haven't we? So it's the health integration first, right? Let's, over to you, Ali Gilbert.
Evening, everybody. I'm Ali Gilbert. I'm the North Place Development Director, and I have included in your papers this evening the papers that are in the public domain and were presented to the North Health and Wellbeing Board recently.
Do you mind bringing the mic closer to you?
Yeah.
Does
that sound? Let's bring physically closer to me. Is that better?
Yes, it is.
Okay,
yeah.
fantastic. So the papers you have in your pack are the papers that are in the public domain and on the North Health and Wellbeing Board website, and they provide an overview of the development as far as we've taken it. It gives you some examples of what are beginning to emerge in terms of the actions around the local area partnerships. And it also provides an overview of the way that the North Place Board, that's accountable to the Health and Wellbeing Board, is thinking about how we evaluate the development of place moving forward, and the maturity matrix that we are designing with partners in the system. So there are some appendices there. The intention, and I'm assuming, and I'm looking to yourself, Chair, that you would like to provide some questions and scrutinise the intelligence that's in front of you. There is more up-to-date information that's available because this is continuously evolving. This was quite a few weeks ago, so I'm happy to take some actions to send around the information and the presentations that provide a current update from what happened before Christmas as well. But I'm happy to take some questions on that too. Thank you.
Thank you, Ali Gilbert. Do you have any questions on this topic? I have a few, but I'll reserve that. Councillor Lee.
Thank you. Those meetings are very interesting, and I've had the honour of attending several of these meetings. There's just something I don't understand. When I look at the focus points that came out of the Kettering rural and Kettering urban meetings, I see that access to services was the action point. It was elected as the point that is very important, and I completely agree with that. That's also what my residents say. They're struggling to access services for all sorts of reasons, anxiety, availability of services. Yet, when I came to the Budget Scrutiny Committee meeting yesterday in this room, I think it was yesterday, I was told, well, the LUPs have identified where we can make savings, and I believe, was it £156,000 that will be cut to push residents into finding the proper channels to access services. And a specific reference was made to the LUPs, as the LUPs having found ways of different ways in which residents can access services, so cuts can be made. Adele was there at that meeting. Maybe she can correct me if I had the wrong impression. But there seems to be a conflict somehow. On the one hand, we need to help our residents access services. On the other hand, we're making cuts to access to services. So I don't understand how those two can sit together. Thank you.
Okay, thank you. It's a good challenge. I wasn't in that meeting yesterday, so I'm going to have to look at
colleagues.
If you leave that with us, Councillor Lee, because I wasn't in that either, because it was the enabling services budget scrutiny yesterday.
Right.
So neither ourselves nor public health were in those discussions. So if you can leave it with us, we'll look into it and come back to you outside the meeting.
Sorry, we need to discuss this outside the meeting. Is that what you said?
What I said was neither Ali nor I nor public health were in that meeting yesterday because it was an enabling services budget scrutiny. So you can leave it with us. We will try and understand what the proposals were.
Okay.
I'm not aware that there would be any proposals around LAP funding that would have...
No, it wasn't LAP funding. I think maybe you can help.
I can probably assist with this, Councillor Lee. There was a proposal around some of our customer service centres, so where we have customer service advisors in outreach areas, and whether we still require those in there. So there's a proposal around savings. It was more around understanding where our customers go to, where the data says that they need us, and whether we need to, move them to different places or whether they still require us in those places. So it was the start of a piece of work of understanding where our customers need us and how we can provide the best services to them with what they need at this current time. So starting to work with our customers to access services in the best way.
But that would be in the rural hubs. So that conflicts with what we see here, that the labs identified that access to services in Kettering rural is not that easy. So do need... Anyway, I wanted to point that out, that to me that seems like a conflict thing.
I think they'll come back to you on that, Councillor Lee. And any further questions? Yes, Councillor Best.
Thanks, Chair. I noticed that the meeting, East Northants North, that was held at the beginning of October, when I kind of read what was written there, critical but not very forthcoming with ideas, sounded a little negative. I'm not sure what your thoughts are on how we do move that forward. Many of the things that were listed are kind of some of the inherent problems of having a more rural community, and not anything that anybody can do anything about, I think, practically. But I don't know if you know what was the mood of the people there, what was the mix of the attendees, and how do you think we'd maybe move that one forward?
So if I may give you a live update on the maturity of our local area partnerships, there is a spectrum. Some of them are functioning very well, collaboratively with a joint ownership of a problem that they're identifying and a challenge, and the solutions coming through. That is one of our weakest local area partnerships at the moment, and we're recognised as we're evaluating the strength of all our local area partnerships, wrapping the right resource around them, and sometimes you never know who's going to be in the room. Sometimes you can have a smaller group which is really energetic and very focused, and then a larger group that gets out of control to a certain extent. So I would say this is still work in progress. But the second part of the paper is showing about the development and maturity of place and how we get a grip on that. So we're recognising as a programme that we now need to think about the strengths of the programme, the weaknesses, and the variation between the laps as well. So probably what you're seeing coming through from that lap was the environment and the culture in the room was probably not very solution-focused or collaborative. And sometimes you do get individuals dominating, as you would, but we're trying to make sure that we've got an open invite and not being prescriptive, and the right people in the room. And I think we're being probably very honest in our feedback to you in these papers and to the Health and Wellbeing Board, so to make sure there's transparency about that maturity and that spectrum.
Okay, thank you.
I picked up on that as well, Councillor Best. If you look at the diversity in the engagement and the usefulness as well, lack of representation from adult services in the Wellingborough West, proactive ideas and suggestions in East Northants and East Northants South and Corby, and not forthcoming with ideas is what Councillor Best just said in East Northants North. But I think you've answered the question that I had, which is how do you modify and adjust the attendees to increase effectiveness of these meetings. Thank you. Councillor Norman.
Thank you, Chairman. I've attended, as you know,
You have indeed, yes.
most of the Wellingborough ones, and indeed one of the early Corby ones as well. Your point about you don't know who's going to be in the room is quite valid, because you know, sometimes you get a preponderance of one particular officers and community organisations interested in one particular area, and it tends to push the discussion in one way, and then the next time a different set come and it pushes the discussion, though you often go to east and west and the same people are there. Mm-hmm. And what we're not getting, and I think you know this, are the members of the public and the service users and the people who ultimately we're trying to help. My first question will be, how are we going to get? What stage are we to get more of the public and a wider variety of people coming? The second thing, I'm still, and it's something I've mentioned before. There's still no, as far as I can see, certainty of any funding for projects and things like that. And there's no defined pot of money, as far as I can see, that's shown anywhere. I did wonder who was on the delivery board. It mentions the delivery board several times, but without saying who's actually on it. And if you look at 4.3, there was the initial sift of projects. I mean, virtually all bar one or two of them had, for instance, community transport and travel as a major problem. But that seems to, but a number of the issues seem to have drifted away from that to other quite specific and tight things that maybe are not getting the best out of the people that they're getting the widest benefit. My last point. Are you confident, and I noticed this is the health and wellbeing report, so it has, are you confident that the message that's coming from these labs is going up the chain and being acted on higher up the chain? Because unless there's buy-in all the way up, there's no benefit.
Thank you. Right, let me go through all of those. So I'll start from the front. So in terms of the functioning of the labs and the people who are engaged within the labs, what we've put in place is we've put in place task and finish groups which link into the labs, so the engine rooms, the doers. We've got the engagement happening through the labs, identifying the priorities, which is the open invitation. Once they agree that priority, a task and finish group is then set up to address that priority, and there is a specific invitation to the right people with the right skills and the right expertise, very program focus and a real grip on it. So we've put an infrastructure around the labs to manage that, but what we don't want to do is exclude people from the labs. We want to keep that momentum and engagement with it. So that's beginning to come through, because that's where you're going to get your delivery focus. So that will help. What we've just described about whoever's in the room and then the loudest voice within that. So that's being supported and managed, and there's fruition coming through from that in terms of delivery. In terms of public engagement and community engagement, there's been a strategic steer from myself and from the place board, and I'll explain who's on the place board shortly, that we need to have a collective conversation with the public, and we haven't been collective in the way that we're all working together. So the program's come to the phase now where we've got a much more collaboration, clarity of our priorities, and we've got something much more tangible to have the collaborative conversation with the public. So we're working with comms leads at the moment, and we're beginning to start to do that through some of the campaigns, and you start to see that coming through in the next couple of months. So that's the next phase, which is why we haven't done it up to this point. That does not mean to say that we haven't taken note of what public have been saying with previous surveys or people who were involved in it, but we will do something much more formal. And I think it's a good message to our public that what this is trying to do is show that we're all trying to work together as public and private sector and voluntary sector, and trying to help them with their solutions collectively. So I think that will address that. There is a pot of money, moving on to your third point. There is a triangulation of 3 funding streams, which we've had from the Integrated Care Board, from public health monies, and from monies within the council as well. So there's a pot of money. So it's an integrated fund which is invested in the model. That money is there to completely invest in the actions and the priorities of the lab. So it's not for the infrastructure, it's there for the doing. And there's a governance process which we've taken through our place board and the Health and Wellbeing Board to make sure that we've got absolute total financial grip on that. And that's actually really innovative, that we are doing different pots of money from different parts of the system, which shows that collaboration at the moment. Moving on to the Place Board. The Place Board has got the executive directors or the nominated lead from all the partners that sit around the Health and Wellbeing Board. So it is the engine room, the executive engine room driving the development. So that's a really good group to provide that oversight. And then you get the feed. Your point about how does it go up the chain? They have continuous updates from the LAPs, the unblocking, the challenges, and the community wellbeing forums. That goes all the way through to the Health and Wellbeing Boards. It's a very much a bottom-up approach, not a top-down approach. I think an important point within that is that the 4 chairs of the community wellbeing forums, also now sit on the Health and Wellbeing Board, so they can be a voice for that community. So the Corby Health and Community Wellbeing Forum Chair will be a voice from what's coming through from the Corby area and the Corby Lap. So we've got the right leadership, the right community voice, and that culture. It's taken a while to shift it around, but I'm pretty confident that we've got that in place. And also on that Place Board, the executives that sit around that board have then responsibility to take it back into their own organisations. So it's not just through the Health and Wellbeing Board, it goes into statutory organisations. And very often there's an ask for various approaches and commitments behind that. And then just the final point, I believe, community transport. So any themes, common themes that are coming through the LAPs, community transport, every LAP was saying this is an issue for us. So what we have done is we have, rather than duplicate, we've pulled together a North Community Transport Oversight Group, which connects to the LAPs, because we didn't want to have 7 different meetings. So we're having one meeting to address that, which links with the voluntary sector, what's happening within the council and the place and economy, and making sure that we're thinking about the people of Northamptonshire and the issues around community transport. That's in its early phases, but it's moving through the motions, which is why you're probably not seeing that thread through the LAPs. I believe that's...
Yeah, I think that's supposed to... Is that a duplication of the VCSE focus boards that are already on... I mean, server running community transport one night, or is that a separate?
So what became very clear in that early day is that we weren't having a collective conversation when that priority rose its head. So that forum I've just described, which I chair, has got the voluntary sector, it's got statutory sector, it's got everybody having one conversation about the service offer, the gaps, what's coming out of rural labs, what's coming out of urban labs, how we problem solve together, and then that can go back into the labs. So we didn't think that there would be a common theme, but there will be common themes, community transport. So we're testing a new approach on that, yes.
Thank you. Thank you, Councillor Lorman. And I think you've answered a few of my questions that I had as well in that. Do we have any further questions on this item? No? Thank you, Ali. Thank you for that. Let's move on to the next item, which is the specialist drug and alcohol. Are we still going on this agenda? I missed the... are we going on this format? Mr. Councillor Best. I think we've done short breaks. Right. Yep. Okay. Well, short breaks and respite. Item 10. David Watts. Thank you.
Yeah, it's Sharon Blount. I'm Commissioning Manager at Northamptonshire Children's Trust. I have my colleague just over there, Jane Amanda Stevenson-Glynn, and we're here to update on bringing a paper last year before we went out to consultation. So we just want you to know the results of the consultation undertaken October, November last year. Note the proposed new model of short breaks, and note the next steps taken to commission the new model of short breaks. I'm happy to do a brief update if you want me to.
I think a brief update will be good. Yeah, thank you.
So short breaks are services for children with disabilities, their daytime activities, such as Saturday groups, youth clubs, and holiday clubs. They also offer overnight breaks for children with disabilities. They've been collaborative right from the beginning of this project. So we're working across Northamptonshire Children's Trust and the ICB, Northamptonshire ICB. We also have representation from both the North and the West Councils. We're linking in and we've done 3 phases of consultation with families and practitioners within the service, so it's been very collaborative. We want to keep that going throughout the project. The aim was to develop sustainable services for the future and giving children with disabilities the services they need at the right time and in the right place. We also, what we wanted to aim to do was to shift the funding from the specialist end of the services into the earlier help end, which is the non-residential short breaks, in order to increase that earlier help, that earlier support in the non-residential short breaks. So that was our aim from the outset. As I say, we've done 3 phases of consultations, so we've done a lot. That started back in 2021, and the end of last year we finished our final consultation. Jane Amanda can update you on the results of that.
Thanks, Sharon. Hi, everybody. So that last phase of the consultation was October-November time, and we ran a survey and we also ran workshops across various locations across the county. We had 150 survey responses, and we ran 10 workshops, and we had 135 attending the workshops. Both from the survey and the workshop was a mixture of parents and carers and service providers and also other health professionals. There's a breakdown of some of the responses from that engagement in your report, but the key items I wanted to note were the changes that we made to the proposed model as a result of that consultation. So we listened very carefully to what people had to tell us, and 3 key changes that we made were removing the sleep service from the proposed model, because it was felt very strongly that sleep service needed its own review, and we will be undertaking a system-wide review on the sleep service to see what improvements we can make with that going forward. At the moment, there's a very long way into the sleep service, and it was felt very strongly by our parents and carers and our professionals across the board that the sleep service should have a separate review and not be included in this model. So we have removed that from the model. We also listened to the idea that we were having about a single referral route in and possibly using an early help assessment to do that. Again, it was felt very strongly, particularly from our parents and carers, that where there were existing assessments in place, could they also be used as a route in rather than parents having to go through yet another assessment when they've already recently been through one. So we've also made changes to the routes into the new service model, more than one route, so that people don't have to redo assessments where it's not required. And finally, one of the proposals was to shut the residential short night breaks 1 night a week to free up some capacity to increase the daytime respite offer. Instead of that, again, on the feedback from service users and also professionals, we've done modelling on bed capacity and kept the residential short rate overnight open 7 days a week. Thanks, Sharon.
Thank you.
So paper was taken to the ICB board 21st of December, and the paper was agreed. So the next steps are to start the commissioning of the services. We're hoping to get the services in place by the 1st of November next year, and we're happy to take any questions.
Thank you. May I start off by saying this is a brilliant in-depth report coupled with comprehensive consultation, as we've just heard. And it's a very satisfactory uptake and participation as well. You mentioned on 5.1 about advertising. How do we intend the service to be advertised to, of course, the people in need of it? .1 of the initial papers. We go to it as well. Oh, papers are everywhere. I don't think it's yeah.
Apologies for that.
Thank you.
I didn't print my papers out right. Simplifying the process. Sorry, can you repeat your question?
Just how will the service be advertised to the people in need of it?
Okay, so we're setting up a function within the new central team where we want to engage with all partners and with all community groups as well. We want to have an understanding, so it will be down to the provider in order to set up a function that could be set up in multiple ways. It will be overseen by us, the commissioners of both the ICB and NCT, to ensure that they are engaging with the local community, with parents. We want to set up a board and have parents on that board. We're going to approach the operational management of the service in a slightly different way, where we're as a group, as a collaborative, with parents involved in that. So there's always that challenge, you know, and responding to that. So being out there in the community, really understanding what's out there, what the need is, and continuing that consultation, that ongoing, to really understand what it is that families with children with disabilities need. Do they know about it? We did find out that we could do a lot better when we did our most recent consultation. All of that information that we've gathered will be passed on to the new provider as well.
Yeah, it was fantastic. Thank you for that fantastic consultation. And I think the bit about single point of access, which I think was picked up in the surveys, is critical in healthcare circles. This is a further question before I go to colleagues. It's a large and complex service which requires competent provider to ensure that the budget is spent wisely and the objectives are met. Are we going to require prior experience? A provider that's had similar experience or proven track record for the bidders?
Absolutely, yeah, absolutely. It's essential. We can't run these services with an inexperienced provider. It's absolutely key.
And thank you for that follow-on question. Will there be monitoring protocols embedded within the contract, KPI reporting as standard?
Yeah.
Thank you. Colleagues have any questions? Yeah, I'll go to Councillor Lee first. Sorry.
Oh, sorry.
Thank you, Chair. There is a long waiting list for the residential stays. That's what it says here. There's a long waiting list. So somehow that's being taken out of the equation now, and that will undergo a separate consultation. I don't understand why that conclusion is made. There's a long waiting list for dentists, but then you don't say, oh, well, let's just wait and we'll look at that separately. No, the fact there is a long waiting list means there is a high demand for residential overnight stays. So why are we not keeping that? It's probably a cost saving, a choice that needs to be made. But the way you phrased it, saying there's a long waiting list, so we'll take it out of the equation and we'll look at that separately, that seems to build in delays for the future. Please explain, because I probably misunderstood that. Thank you.
Do you want me to respond to that, Sharon? Are you okay?
Do you want to go?
Yeah. So, just sorry, I might not be clear. So, what's been removed is the sleep service from the service model, not the residential short break. So, I do apologise, Councillor Lee, if you misunderstood what I said. And that was based on the feedback we got from parents and council service that the sleep service requires a system review. For example, a huge amount of inappropriate referrals being made to sleep service, which adds to the waiting list. If we look at it as a system across the ICS, then we can hopefully make quite some dramatic changes that will reduce that waiting list and get people seen quicker.
Thank you. That was my misunderstanding. Thank you.
Thank you. Councillor Jackson.
Thank you, Chair. Unfortunately, my question is very similar to Annalise. How do you ensure that all the parents stroke carers are able to access the same service in all the different areas?
That is a bit more of a challenge, and one of the reasons for redesigning the services is to try and improve that access. We haven't got it perfect at the moment. We do want to do better. We hope that we can understand, and the key to this, I think, is understanding what the need is within all of the different areas, and we don't understand that at the moment. With the daytime activities, the non-residential short break side of it, what we want them to do is change how they deliver in the new contract to really understand each of the areas. And in the north, that would be East Northants, Wellingborough, Corby, Kettering are the main sort of areas. And they may all be different. At the moment, we've got, the same service going into each of those areas. We want innovation. They want them, as I said earlier, to build those links with the community to understand it. I think building links with the LAPs as well would be absolutely key, because transport is another issue. So it's a more refined model, this new model. We've listened to what everybody has told us. We've adapted it, and hopefully we can build the service to better respond to the need and give them not necessarily exactly the same in what's every area, but what's needed in each of the smaller areas.
Thank you.
Does that answer your question?
David, I'll go over to David.
Sorry, just to add to that, I mean, I was going to make the point around the local area partnerships and understanding the uniqueness of some of our areas. What a lot of parents do say as well is they don't necessarily want the same services, so don't necessarily want exactly the same offer across the piece. And I think it's fair to say that we want to develop it, so having a vibrant offer with the sorts of things which support people's needs within their local community is really where we want to be to, where we want to get to. How do we create the right sorts of environments in communities so that people feel really well supported in that local area? One of the bugbears that I've dealt with as a social worker in adults is quite often people have been travelling a long way for respite or to access activities, and really what they would like to do is access them in their local community or take part in their local community. And when you look at some of the feedback of young people around particularly the daytime activities, they're very much saying to us, I'd like to do the sorts of things which my peers are doing that don't necessarily have special educational needs or disabilities in that sense.
Thank you, David. Councillor Best.
Thank you. My question's about trying to find this service provider, and I can see we've got a plan to do that. I'm hoping we've been in touch or are in touch with peer authorities who've got similar needs and maybe already have service providers to understand who's out there and how they perform and how they compare cost-wise.
Yeah, so we've done a couple of provider events as part of the consultation. We do know a lot of the providers of the services haven't delivered them for so long. So we have been engaging. We can do that up until when we go out to procurement, and then we can't anymore. So we have been engaging and working with potential providers. They've been included in some of the consultations, so hopefully they understand, because it is a bit of a change from what we've done before. So yeah, we've done all the preparation for that. We've also built in some negotiation into the tender, just in case, you know, we need that, which we haven't done before. So, yeah, we've tried to think, you know, of all the barriers that might stop this from working, and done what we can.
Thank you. Councillor Lorman.
Thank you, Chairman. You know, I had the opportunity to see this at an earlier phase, and it's really pleasing to see it getting to this stage. It's a very comprehensive and inclusive piece of work for, you know, people who obviously have individual needs and you know, not the easiest to cater for. It's just a shame that the procurement process takes so long, which is a bugbear we have to bear all the time. But what I just did want to get some clarity on is the interim period that the service will continue until the end of October, because one thing I noticed in here, it says demobilisation on the 5th of August. And if you demobilise, you're not offering the service, and obviously August and September are prime times for people to take breaks and when the weather's better. So you know, that you know, look, it could be lost if we're not careful. So just wanted some clarity as to what will happen in that period, you know, for people looking to take breaks.
Yep, so for residential short breaks, our provider will continue until the new provider. So there will be, you know, hopefully a seamless handover from one service to the other. So that will start quite early. As soon as we award to the new provider, then that process will start. We hope to have a service manager in place very quickly to start understanding picking up the service. So it's absolutely key, as you say, that there's no gap. Because the impact on families, we want to make sure that there's minimal impact. There will be some, but we want to minimise that as much as we can. So yeah, that's all agreed.
That's your question. Thank you. Thank you. Any further question from colleagues? No. Thank you very much. Moving on to item number 8. I believe we're doing 8 now. The specialist drug and alcohol treatment services for individuals rough sleeping or at risk of rough sleeping. Susan Jackson.
Chair, I'm presenting this. I'm Jane Bethay. I'm the Director of Public Health. So I'm not Suzanne, but presenting on Suzanne's behalf. So I'll take the papers as read, but this is a great opportunity for us to come here and talk about investment in a really important area of vulnerability. So what this is actually about is investing public health reserves money over 2 years to a total value of £600,000 into a service that will provide wraparound outreach-based support for our rough sleeping community and for those at risk of rough sleeping. And I'd just like to start really with a really frightening statistic, which is a woman who rough sleeps has an average age of death of 44. It's a very vulnerable group. They have enormous needs around a whole range of different areas, including mental health, including substance use, and often those are co-occurring, which compound each other. So the model that you'll see in the papers is about having an outreach service. This service will bring together physical and mental health and drug and alcohol workers to provide that wraparound support for people where they need it. Now, I've been involved in working with people experiencing homelessness and rough sleeping for a long time. I was the public health lead under COVID for the area I worked in before I came here, and I understand this population. And this population, you need to build trust, you need to work with them intensively, but the rewards you can get from doing that work are very significant. You can move people into a recovery phase. We saw that in COVID, and we think this is the right model to get where we want to be in terms of helping people think about their future and a future where drugs and alcohol are not part of that, because we know many people who go into rough sleeping, that is an existing problem for them. The other thing to consider is where that isn't a problem, we know the evidence suggests it often becomes a problem. And this can be because people are coping with extremely difficult circumstances when they're rough sleeping. So I'm available to answer questions, but this is a joint venture between public health and housing. It is being funded in this way, and you'll see this in the paper, because there was a funding opportunity a number of years ago now that this organisation, I don't think even existed actually when that particular opportunity came out. So I'd like to invest our reserves into something that I think will bring significant benefits, not just in terms of health, but in terms of criminal justice, in terms of housing, and in terms of a range of services. So open for questions.
Thank you. I think it's indisputable that this is a much-needed service, and the prospect of rough sleepers being able to access wraparound support and rehab services is absolutely vital. Reading through the report, there was nothing stated in there about working with community groups and charities. I think working with the likes of, let's just go to Wellingborough, my constituency, Teen Challenge or Daylight Centre, they know the rough sleepers, they know where they are, they know what they do, and they've already built trust with them. Is this something that this service intends to do, joint working with these charity?
Absolutely, that is absolutely the case. And already, so we have a very active street outreach service locally who also have an excellent relationship with both those organisations but the individuals experiencing rough sleeping. It has to be a joint effort across all sectors because you have to get the right offer with that trust at the basis of that, really to get to where we want to be. So yes, it definitely will be involving a whole range of different organisations.
Thank you. I've got other questions, but I've been up to colleagues. Councillor Lee.
Thank you. A very interesting paper. Thank you. At the moment, when charities refer or dedicated services refer addicts to mental health services, the mental health services apparently refuse to deal with addicts who are still addicted. So this is very welcome to have these services provided. Now, I just wonder how many places would be available overnight, funded places overnight, because I think we only have a centre in Rushden, but will this money go towards it? Because it just seems to be funding positions, functions, employees. Will there also be services available overnight? Because addicts need to stay somewhere where they're cut off from the rest of the world so that they can overcome their addiction.
I think what you're describing there is rehab, actually. And so there are rehab options. We fund rehab. The big issue is getting people into it. So just to return to your first point, because it's a really important one. So in old money, this used to be called dual diagnosis. We now say coexisting substance use and mental health issues is a major issue. So as well as this work, just to give you some assurance, Councillor Lee, the system is doing a lot of work through the Combating Drugs Partnership to get a better offer for everybody who has coexisting mental health and substance use issues, not just for those who rough sleep, although they have particular issues, as you can imagine, around stigma and a whole range of other things. So, so in terms of this offer, so what we want to be able to do is engage people and get them into treatment. So that what this isn't necessarily about is about getting people housing through this service, but it works with housing to support people into tenancies. Rough sleep is an extremely complex issue, and it's not enough to really just provide somebody with somewhere to live. You've got to look at their needs, their basic issues which may be really working against them in terms of maintaining a tenancy. And we know that if you get the right offer around drug and alcohol support, mental health support, and then work with housing and work in a very joined up way, your chances of success for that individual are so much higher. So this is building that blueprint for cross-organisational working around the person. I hope that answers your question. So it's not about providing accommodation as such, but that point about getting people into those opportunities like rehab, this is absolutely what this is about.
That's your question. Thank you. I've got a few more questions. I'll give colleagues time to come up with this. So I have an alcohol problem and my mental health is spiralling. Who do I call? Where do I go under this strategy?
Sorry, say that again.
So it's more about access and process. How can rough sleepers engage with this service?
Okay, so this will be a proactive outreach service.
Right.
So, so what it will be, we'll be working with street outreach and with people with those trusted relationships. So it should really be the case that anybody who is rough sleeping, or anybody, should be able to work with health professionals or social care professionals, and those professionals should know where to support you into in terms of your drug or alcohol problems. Right. That is something we're moving to as a system, and we make quite a lot of strides in that area. But for this particular group, this is an outreach-based model. Right. So when, for example, our street outreach team go out, you'll see from the papers, our street outreach team know a lot about this group. They know, for example, that 80% of those who are repeat rough sleepers have a drug or alcohol problem. So they know them. So we're using that trusting relationship to get the right support where that person wants to access it. And that's really critical for this group. This group are less likely to engage in a traditional delivery offer for services. So it'll be around the person, very proactive and very outreach focused.
Thank you. Can they be referred by charities like Teen Challenge, for example?
Absolutely.
And there's a clear line of process for that.
Yeah. Is it worth me just saying what that is? Because
yes,
we have,
please, yeah.
So Public Health fund a whole range of drug and alcohol services, and these are available to anyone. So anybody experiencing rough sleeping right now can be referred into those services, and they are referred into those services. It can be a self-referral, it can be through the GP, it can be through anybody. Our main adult provider is an organisation called Change, Grow, Live, and they have offices and buildings. There's a brand new one in Corby, for example. We have them in Kettering and across the patch. What the difference is in this one is the outreach nature of it. So going much more to where that need is and working on a almost street basis actually to get the right offer to at the right time. So we do have the service itself. There isn't a waiting time for the service. So if you're referred in for drug or alcohol support, it's not a waiting. You have no waiting list. You can get that support straight away, and that's something that's really critical for services like this. You need to get somebody when they're ready for that support. Putting them on a waiting list is a problem.
Yeah, thank you for that. And does that go for both known rough sleepers and obviously new rough sleepers as well? People that are known by the system, that you can verify them being on there. And there isn't any, I think you've touched on this, there isn't any specific requirement in order to get onto this service and get the help they need. Thank you. I've got a few other questions. The colleagues got any questions on this? Yeah, Councillor Best.
Yeah, thanks. I think in your plan you talked about having maybe 7.5 time full-time equivalent people to head up this service, I guess, or provide it. Where are you with getting those people on board? Do you have some of them already? Are they already earmarked, or is it new recruitment? And how do you think that's going to go?
Well, some of it is existing team members, actually. So some of the team you'll see in that structure are existing members of staff here who are already supporting the homelessness endeavour, if you like, for Northants. What we'd need to do for the rest of those workers, because they are specialist workers, we're looking for drug and alcohol workers, and we're also looking for workers from health, so people who've got specialties around mental health and also physical health, because we want to get that offer right. So that will mean having to do some procurement exercise, and it would probably be, we do have a market for that. So we do have an existing provider, obviously though, that it will have to go through a process for this, who have got workers who could move into those roles, or they could recruit people into those roles, and the same for health. What I find with these sorts of roles, if I'm being completely honest with my previous experience in this world, is you often find people who are very committed to working with this group. And actually, strangely, finding people to fill these roles, in my experience, is not that difficult because it's often a very vocational thing. So I don't anticipate issues with recruitment, but it's very important to get the right person in that role.
Sure. Okay. Thank you.
Thank you. Just on that point, reading reports, what are the academic qualifications for drug and alcohol coordinators, for example? If you don't mind just going into what they need to do.
So lots of different workers work within drug and alcohol services, and that's really important to have a really varied offer. So you'll have more senior workers who may be managing staff. What they all have are key qualifications around how do you actually work with somebody to get them into recovery. Some people will have lived experience themselves, and that's really important. Yeah. What we know from drug and alcohol services is having that relationship, particularly in that recovery phase, where it's not about treatment. So, for example, if you're going to give somebody treatment for like opiate substitution therapy, you've got to be qualified to do that, and there's certain people that do that. But when it comes to recovery, which is very critical, we will have people employed in roles across all of our drug and alcohol services who have lived experience and who build the trust because they've been there. So it's a really varied picture for this whole team in terms of qualifications. There will be some things they absolutely have to have in order to prescribe, for example. So there's a non-medical prescriber in that model, for example. But for the main recovery workers, the most important thing is empathy, is to have a really good understanding of the local offer, to have a really good understanding of that person's situation, and some of them may have that lived experience themselves, which brings an added benefit to that relationship. But we have quite strict, all organisations put people through training, but they also have a whole range of other safeguards in place as well, as you would for any other service, children's services, for example. But the most important thing is getting people in who can connect, who can build trust, and who can really put themselves in the shoes of that person, because that's where the success comes.
Yeah, thank you for that. My final question, do you work with S2S, for example? I think they call it a substance to solution. Are you going to be engaging with them as they provide a rehab services as well, similar to what's described in this report? They're in Wellingborough. I don't know if you've come across them.
I can't tell you specific organisations because I don't know them all yet. I've not been here very long. I've been to some organisations, but so I can't give you I can come back to you on that one. But what we always try and do is work with all the organisations locally, because we need a really varied offer. We need an offer that meets people's needs, and we need an offer that's evidence-based, that we know is going to have impact. So I can't tell you about specific ones now, but we can come back to you on that one.
Yeah, no, thank you for that. A great report. Any further questions? Oh, yes, Councillor Lorman, and then we'll get to you.
Thank you, Chairman. This is obviously a very complex area, and I don't underestimate the importance of the work. I mean, even back in the old borough days, there were officers talking to rough sleeper virtually every day and knowing what they need. And your point about wanting to engage was well made, because quite a number didn't want to engage, or they just didn't want the responsibility, or had friends there for whatever reason. So I can understand. But my question is really around the statistics in the because I was a bit confused, to be honest. In 4.10, we're told that 33 people are in the target group. In the chart one, we're told there are 25 at the latest count. On table A, we're told there are 9, and then table B, 199. So numbers going up and down. I know that they're probably all slightly different things, but it is. And when you add all the people up, we're talking about 22 full-time equivalents to run the various services that are there. So it's I mean, if I remember the public and I saw there were 9 rough sleepers and we were spending 300,000 and there were 22 people doing it, I think that was more value for money. It's obviously misleading, but can you?
Yes, figures around rough sleeping are notoriously difficult, I think is the first thing to say. So the way that it's measured or counted is something to first consider. First, in 4.10, that 33 is repeat. People who are entrenched, if you like, and they've been picked up a number of times. Now, this group is particularly challenging. So this is the group who we may need to do more work in around engagement, because they've been rough sleeping more than once, and they tend to be more complex. So that's why that's a different figure. That's a different subgroup, if you like. If you look through the pack, there's a monthly count that happens, and you'll see that the monthly count, what happens is on any given day, a snapshot of where people are known to be. So the street outreach team will identify people that in the place that they tend to be found, rough sleeping, and that goes as high as 26 counted in a single month, in a snapshot on one day. So it's very difficult. We get transient people, so we get people who move to different areas, or we have people who are rough sleeping for a short period and something happens and they get out of that, which is obviously fantastic. So it's very difficult. It's a bit of a moving feast. However, what I would say is that even 33 repeat people experiencing rough sleeping are very, very complex. The impact of working directly and intensively with that 33 to move them into a different position is enormous. Actually, the savings that you get from working effectively with that group have been well documented, in evidence and research. And although that team does feel quite big for that 33, that's also a subgroup of a much wider group. So we have the rough sleeping group, but who probably are more like 100 overall, but again, it varies, it moves at different times. If we say we find 26 on a given night when we do the snapshot count, that is still the people we find. There will be other people that we don't find. And then the big group to consider is the at-risk of rough sleeping group. So there's a group also teetering on the edge all the time. And what we need to do is work with them intensively, and this work includes that group as well, not just the people actually experiencing rough sleeping. So that's a much bigger group as well. So I completely take your point, Councillor, about the group figures being different. It's a superbly difficult thing to get an absolute figure on that, but the work that the street outreach team do to get that figure is quite significant. I'm actually going out with them to do a count. I was meant to go in January, but I think I'm going in February now, to see where they go, because it's not going to be everybody, but it gives us at least the same methodology every month to give some comparison as we go through the year. So we're never going to exactly know, but the 33 are the most difficult ones because they're the ones who have repeatedly gone into that cycle. Excuse me.
I think there's a need to emphasise, it's too late for this report now, but about the prevention side of it, though, and the working with people. I know the housing will work to prevent homelessness, which is different, but the working to prevent rough sleeping as well is worthwhile, obviously, both for the person and for the council. Maybe that should be emphasised more.
Thank you, Councillor Lawman. Councillor David, please. Thank you.
Don't tell me with that brush, Councillor. Just to support a lot of what Jane has said there. I've been out with our rough sleepers team. They're not just going and supporting rough sleepers. They also undertake functions on behalf of our housing applications. So if people do claim to be rough sleeping, we have to do a process called verification, which is we have to go and look at the areas where they claim to be rough sleeping. Quite often, that can be an hour a night, a couple of hours a night, which we're out trying to locate those people. Sometimes we find them, sometimes we don't. So there's a number of different functions which they do. They also run drop-in sessions in the daytime as well, our rough sleeping team. So they will be in community centres. They will pass on details to people that they do find rough sleeping who are saying, I don't want anything to do with you. They repeatedly engage with them. And they're a fantastic group of staff who work tirelessly to try and support people. And they will have experiences where they've supported people into accommodation which has failed, but they keep going back, they keep working with those groups of people to support them to find the right sort of accommodation and try and sustain them in that as well. And I think it's like Jane says, it's less about referral and more about we know where they are. It's more about catching them at the right time, at a point in their life where they're saying to us, I'm ready to engage now. I'm ready to either access treatment or access mental health support and also sort my accommodation out at the same time. I think transient population is something which we struggle with as well. We've got a major train line that runs through a number of our key towns, so we see people moving between them, and we do see people coming in from Leicestershire, people coming in from other areas south as well. So that can be a difficult population for us to manage as well.
Thank you. I think in terms of verification, we often have rough sleepers moving around to different places. They probably have about 3 spots. from the intel within my constituency. And I think it's a very good idea to work with the charities, the community groups that are supporting them to know where they are or where they could be, and also they move when the conditions of the weather change as well quite a lot. So I believe there was an issue recently in Wellingborough with that when the temperature went to -2. So verification is obviously a key topic within the rough sleeping sphere. Do we have any further questions? Well, we note this report, and I'm sure will be brought back at another time. Thank you very much. Thank you. Right, so let's move on to agenda item 9. Are we going back to 6?
I think we'll move on to 9.
9, okay, right. Thank you, over to you.
Thank you, Chair. Can everybody hear me okay? Yeah, good, thank you. So, good evening, and thank you for inviting us this evening. First, I'd like to introduce myself. My name is Mick Jones. I'm the Division Director for EMAS for Northamptonshire, and to my right is my colleague, Martin Claydon, Head of Operations. So my plan tonight is just to give a brief overview of what we do as a region as EMAS, a few slides, and then what that means to Northamptonshire, then talk about our strategy, our 5-year strategy, and where that links into our clinical strategy. And I'll hand over to Martin then, who will talk about local performance and local issues that just to be aware of, really. Thank you. So what is EMAS? EMAS is a regional service which is over 6 counties of the region of the East Midlands, and it's quite urban and rural in makeup. As you can see, we serve just under 5 million people, and the rurality as well of only 6,500 square miles. We take 3,500 calls a day, 1 every 25 seconds, and we also provide patient transport services within the 3 counties of Derby, Lincolnshire and Northamptonshire. And that's, I think, that key statement on the end, our patients will always be central to what we do. And I think that's a key thing to a golden thread that goes all the way through. Thank you. So this is just a bit of a busy slide, I know, but it's probably a little bit out of date, but our new report's not out yet. So this is where we are as a region and what we do on a daily basis. So face-to-face responses down there in the bottom left, 642,000, only 650,000, 500,000 even. And again, 3,400 calls, 14 calls a day. And yeah, I'll leave the I won't go into that into too much detail, but it is in the report, I believe, but it can be looked at or it can be shared with you. Next one, please. So from a Northamptonshire perspective, we provide urgent and emergency care alongside telephone and clinical assessment for population of Northamptonshire. And I think the key thing to recognise here is that growth over the 10 years of Northamptonshire, how the population has changed, living longer, and then the challenges that does give to us as a service. Thank you. So from a Northamptonshire perspective, we employ 460 staff, and I think that's worth noting that I've been in Northamptonshire for 7 years now, and we've probably just under doubled the amount of staff that we have recruited to. Rather than going into a great deal of detail, in 2017 when I came to Northamptonshire, on a night shift, we was probably putting out 9 or 10 or 11 crews per night shift. Now we're putting 17 or 18, probably 20 out some days. And that's trying to meet the growing demand as well. So in Northamptonshire, we regularly receive around 465 calls a day. That's not to say we actually respond to those calls, and Martin will talk about that a bit later, but that's what we get coming into our call centre. And that's one call every 3 minutes. And approximately 42% of these calls we don't send an ambulance to. We do something else with. And I don't want to take Martin's steam away from him later, but Northamptonshire is one of the top performers in non-conveyance in the East Midlands, which is something to be proud of. We have 8 ambulance stations across the county, and as I said earlier on, we put out between about 17 and 42 double-crewed ambulances a day, along between 5 and 10 fast response vehicles as well. Thank you. So moving on for our 5-year strategy, our vision still remains the same as it's been in the past, responding to patients in the right way, developing our organisation to become outstanding for patients, and collaborating to improve wider healthcare. But we've also developed in our strategy our new 5 ambitions that we want to achieve. And I won't go into detail then read them out because you'll probably get bored of my voice in a minute. But what I will say is that would not done in isolation. That would be done across the whole system, the healthcare system within in Northamptonshire, working collaboratively together, working differently as an ambulance service, because we want to become, we want to be an emergency service, but an urgent care service as well, where other areas nationally want to become an emergency service. But I think we want to meet the needs of the population as well. Thank you. So again, lots of words talk about strategy now. What do we think it means to our patients? I obviously went out and asked what it meant to them. And again, I want to be able to access appropriate and urgent emergency care. I want to receive care in a timely way. I want to receive safe and effective care. I think one key thing for me on here on the top right is I'll only have to tell my story once. The amount of times you go to a healthcare provider, you get passed on, you start at the beginning, you go start again, you start at the beginning. It needs to be that one joined up message seamlessly all the way through. Thank you. And again, this is again working in partnership with our organisations, and this is not about just getting a call, dispatching an ambulance. That is the wrong way to do it nowadays at all. We can't do it with the demand we are receiving. We just can't have the result. We don't have infinite resources, so we need to think differently how we're going to provide the right care. And not everybody wants an ambulance. Not everybody wants to be pointed in a different direction. So it's understanding with other organisations how we can be joined up with that. I think I'm quite fortunate in Northamptonshire. I've got quite good relationship across the Integrated Care Board, Integrated Care Systems with our colleagues to the left here. So I'm really quite looking forward to over the strategy over the next few years to actually develop that further. So let me go on to our clinical strategy. And you see there we're talking about four boxes there that we want to deliver. Our commitment to major incidents, emergency care, urgent care, and the non-emergency patient transport service. And rather go through all those boxes, to take you down to the bottom box, the fundamental principles at the bottom. We want to ensure equity, we want to ensure care closer to home, joined up care, consistent and timely. We want to improve the clinical outcomes, be safe and effective, reducing the health inequalities, and ensure we're delivering personalised care. Thank you. So what does this mean? What clinical strategy, what do we deliver? Safe, effective and compassionate care. The right care, the right place and the right person. Reduce inequalities, definitely improve response times and reduce inappropriate ambulance dispatch. And again, Martin will talk further about that, about a new dispatch system we've just developed now in the East Midlands called Pathways, which does more of a triage as a call comes in and make sure we point the call to the right place. So how is it different to our current provision? Increase our hear and treat and see and treat contacts. So the hear and treat is when you get the call to our call centre, the see and treat is when somebody goes out and sees them. And I think something that was really key to Northampton, we've been quite innovative in developing over the last 12 months, is the specialist paramedic role that we've introduced. So it's a paramedic with enhanced skills, enhanced assessment skills and medication. And we've actually taken them off the road at certain times, put them in a hub in Northamptonshire, and they've been calling our patients back at a time, say, what do you actually need from us? Do you need this, this and this and this? And, do you know, for the life of me now, the figure escapes me, but I think it's somewhere around 65% of those contacts we don't send an ambulance to. They go elsewhere. And it's been now adopted, that model has been adopted throughout the East Midlands to say that is the right way to need to go now. So it's something, I think, for Northamptonshire, personally, to be proud of it. It was a leap of faith to do it. There was a lot of naysayers initially say, are you sure you want to do this? But I think unless if you don't think differently, we'll always get the same result. And the other thing as well is we really would like to do is work a lot closer with primary care, bringing primary care into others as well. I'm a real keen believer on what transformational skills that paramedics have got and how we could probably have a rotational workforce in some form or whatever throughout primary care. And the benefit that would give to our staff, bringing those skills back into us as they would work on a daily basis. And this is all high level stuff at the moment, but it's ideas that we want to do going forward. Thank you. Next slide, thank you. And again, how are we going, all these things are wonderful, and talk about how we're going to be measured on these things, but by a lot of what I'm talking about, we'll see an increase in response times. We will deliver safe and effective care. We will increase that patient experience and involvement. And I said at the start, that is the key thing for me, is that patient at the end of that. And again, I won't go through all that again, but there's our key measures, how will we measured. Thank you, next slide. And then I'll hand over to Martin, who will talk about our performance standards, etc., and then some of the problems we're having with some of our delays at the acutes. And before we go into that, I just want to point out, this is not pointing any fingers at delays at acutes, because they have their problems as well. It is a system problem that we need to sort out, and not one sole provider.
Chair, is this presentation now being chaired online? Because how does the watching public know these slides? We haven't received them. Are they being shared online? They're not.
No, the slides will be added to the website after the meeting. They're not visible on the YouTube stream currently, no.
They will be added to the website.
Yeah.
Thank you.
Thank you. Yeah.
Thank you, and again, thank you for the invitation. I apologise, the next few slides are very number-based. That's because that's what I live and breathe. So just to go through this slide very quickly, this is how we triage our calls. So those calls that come into us, we have to try and prioritise those. So this is around the process we use to determine if a call is life-threatening, whether it's an emergency, whether it's urgent, or whether it's less urgent. And it's these less urgent calls, the category 3s and the category 4s, are where the specialist paramedics absolutely come to their forefront, that Mick's already spoken about. And what makes RSPs, if you like, sometimes more efficient than our clinicians that are based in our control centre, is that they're local clinicians who have worked in this area. They know our pathways really well. They know what advice and guidance they can give, what services that the public can access where they are. So it's that local knowledge that absolutely makes the difference, and allows them to direct patients to a more appropriate place to get the care they need. So this is how we triage our calls. Again, I apologise for the slides that are very number based, if we can move on to. So this is our performance, and we are very much commissioned and managed against our category 1 and category 2 performance, because they are the most seriously unwell patients that we deal with. You'll see from the lines that the target is the yellow and red lines on the top one. We achieve what is called our 90 percentile, so that's 9 out of 10 patients that we get to within that time. Our mean, our average, we are just above, and I'll go on to some of the reasons why and the reasons we are struggling to achieve that target. The bottom chart is our category 2, and we had a recent change from our commissioners that the national standard is 18 minutes, which is the yellow line. The commission target we've been given is 30 minutes. And recently, from the beginning of the year, we were achieving that relatively well as the demand has started to lift as we're going into those winter months where our activity is absolutely starting to come up. We've found that more and more difficult. But this is about prioritising those poorly patients, and that does mean that sometimes those lower category calls do have to wait a little bit longer, which is why we're utilising the SPs to look at other ways of giving them help in a timely manner. So next slide. So talking about the activity, and Michael touched on it earlier, we introduced a new triaging programme within our control centre called Pathways. We were under a previous system that did the same thing. The outcome is still the same, the category 1, 2, 3 and 4. But Pathways is very much more around actually looking at what that person is suffering with. It's very much sort of around their actual clinical need. So we find that the outcome of that is a little bit better to actually sort of triage that patient and give us a little bit more information around what they're suffering with so that we can direct the right clinician to them. But just going on to the activity, we always know that December is going to be busy. It's that time of year. And we've worked into that. Now, our Category 1 calls, when we compare them to last year, have come down. Now, there's lots of assumptions you can make on that about healthier living, etc. One of the issues that we have is, unfortunately, COVID and the impact that had on how patients access health has had a real impact on how we analyse sort of our demand against previous years, because the numbers are all a little bit astray. What we are feeling, though, is it is getting very busy, and our overall activity is increasing. So our Cat 2 patients in November was 7% up on our previous year. And that's a lot of patients that we're now having to try and prioritise. So next slide, please. Again, I apologise for the lots of slides, but this is just to demonstrate that re-triaging, the sort of how we actually manage our patients as they come in. So the yellow shaded area is all of our incidents. The blue blocks are what we've heard and treat. So this is where they will have been spoken to by a clinician. They'll have been assessed to whether they need an ambulance to attend them. And if the answer is no, they'll then be redirected either back to primary care, to their GP, or to an urgent care centre, such as Corby here, or even a pharmacist. All of those other care pathways that are available. So we'll redirect them without even going out to them. The green block is where we do send a clinician. A lot of these people do need somebody to go and see them, either because they've got a condition at that time that needs some immediate care, but doesn't necessarily need to go to hospital. So someone who's experiencing maybe an asthma attack that needs some immediate medication to control that, or an epileptic, those type of people with long-term conditions sometimes just need immediate help and support treatment, and then they're very used to their conditions, so don't want to go to hospital, but they just need that onward support, and again, potentially a referral back into their GP to readjust things and maintain it. So overall, that gives us around 55% of our incidents. We don't take them to hospital. That does leave a problem that we'll come on to around what we take tends to be the more unwell patient. So that 55% is sort of broken down roughly into sort of 30% of that is hear and treat, and 25% of that is see and treat. So a quarter of what we actually go out to, we don't take to hospital. Happy to take questions if it's fresh in your mind, if that's okay.
No,
with the chair.
what did you say? See and treat?
See and treat and hear and treat. So hear and treat is where you don't attend, you just talk to them over the phone. See and treat is where we've actually attended in a vehicle of some description, and we've done an assessment on them and then left them in situ to refer on to another agency.
Whilst we're on this,
yeah, of course, yeah,
we can do some questions. What's the difference with the, I believe the green part of the chart? What's the difference from 111? Is there, because of course they contact people can contact 111 and get through to various urgent care centres, etc., and they can triage them that way. Is it a good use of 999 if you're triaging as well? I just want to understand that.
So actually, it's a really valid point. So the new system that we've got onto, Pathways, is actually the same system that 111 use. So what we've found now is there's an element of alignment with the way that the general public access 111, our triage with those, and the way that we would deal with them. Now, we absolutely would love to make sure that people get through to the right service, 111 or 999, the first time. What we're looking at, though, is if that's not clear to them and they end up with the wrong service, 111 will automatically redirect calls back through to us. Yeah. So they have an ability to triage and say this needs an ambulance response. It then ultimately comes through to us, goes on to what we call our stack, on number of calls, and then we dispatch an ambulance to it. And alternatively, if it comes through to us, we now have a triage system where we can use the same type of clinicians, the same type of system to triage them and redirect them if need be.
Thank you.
No worries. So just talking about acute attendances, and as Mick already said, we know that the acutes are under a lot of pressure, so we are doing everything we can to try and reduce what we're taking through to hospital. And we've seen that our acute attendances are only up by 1% on average, and that's on the back of an overall sort of 1.2% in our activity. So that's absolutely us trying to do everything we can to keep those patients away from that hospital front door. However, we know that some of these patients need to be there, so we have to take them through to an acute unit. So, and I don't want to labour this point too much, but we do lose time. So pre-handover is the time from when we arrive at the hospital to when we can hand that patient over to the hospital staff for them to care with. The target is 15 minutes. That's very difficult for any acute to achieve. EMAS as a whole, for the first part of this year, so April through to November, lost just short of 76,000 hours. Northamptonshire, that was just short of 5,000 hours, which equates to about 6.3 of the whole lot. And I want to be very clear with what Mick's already said. We do a lot of work to work with our hospitals. I attend sometimes daily calls with them to look at what position they're in. And that's not just the acutes. That's a call that looks at the whole system. It looks at the acute units. It looks at our community colleagues, our social services colleagues, because we know that they all need an element of support, and we need to understand that flow through from patients being brought in to patients being discharged and being back into either their own home and cared there or into a community setting. So there's a lot of work done to understand when they're under pressure and then look at what we can do to alleviate some of that pressure. Next slide, please. What we've done to try and alleviate that and to try and maintain a service to the general public is absolutely increase our resources. So Mick spoke earlier around the number of staff that we now have. I have to be honest and say I never thought we would get to the sort of numbers that we've got. You know, when I came into, and I've been in the division a lot longer than Michael, 27 years, we were in single digits some nights with ambulances that we're putting out. We have a core set of resources. We also offer a lot of overtime that we target to those key times when we know it's going to be busy. But we absolutely have to be careful about our staff and making sure that they're getting a good work-life balance. So we're trying to balance that out. And I think that red line shows that the number of staff that we've taken on and the number of extra hours we're putting out is to try and maintain that service to the community when we know we're under pressure and the acutes are under pressure and they're having a difficulty offloading us. Slide, please. So this is that a percentage of lost hours. So whatever we're putting out between April and November, we lost on average about 4.5% of that back to crews unfortunately being held at acute units where they're unable to offload that patient because they're unable to move patients through the hospital and release us. This did peak in sort of December of last year. Well, we had a rather large peak in December at 15.2. And again, the hospitals have absolutely been working with us. They're absolutely sharing the risk is what we talk about. Now, there's a risk of patients in a hospital setting not getting inside. They share that risk with us, and they share, excuse me, the understanding of the risk that it gives to patients left in the community. And the last slide, I believe, that we've got is just to sort of give a bit of an understanding of what we try to do. So when a patient arrives at a hospital and they can't be offloaded, it's not just left with us to continue caring with that patient. The acute units do everything they can to start that treatment with that patient. For us, we talk about patient experience. And why I would love to be able to offload that patient and give that patient to the hospital and go get the next patient. Our responsibility is still for that patient, so we want them to get the best care and treatment they can. So we have a thing called the minimum care standards. Now, this has been set by NHS England, both of the acutes in the area absolutely embrace this, and they provide staff to start that treatment, start that assessment. And there are times when the right thing for that patient is for them to have an X-ray or a CT scan or whatever it may be, and we will take them in, have that, and then bring them back to the ambulance. And this is all while the hospital are absolutely doing everything they can to provide a bed for that patient. But rather than delaying the start of care, we do that wherever we can. The other thing that we have, and the hospitals are absolutely committed to, is what we call a rapid handover bed. So if we get an extremely unwell patient in the community, that category 1 type patient, we can put that request into the hospital. They will make that bed available to us. We will offload one of the patients that we've got waiting to release a vehicle to be able to go to that extremely unwell patient. We also want to take harm reviews. Now, this is around looking at those patients that unfortunately do wait a long time in the community. And we're very aware of it, and it's not what we want. So we review those that have had long waits to look at whether that's actually caused harm and learn any lessons from that. And they're done on a regular basis, both for those patients waiting in the community and those waiting outside an acute unit. And I do apologise, there was a lot of facts and figures in there. I live and breathe this along with Mick every day, so it's sort of second nature to us. And so I do apologise about all of the facts and figures and welcome any questions.
No, I think it's, thank you for that. I think it's absolutely brilliant and very informative. The colleagues have any questions? Councillor Brown.
Thank you very much, Chair. I've got two, if I may. They're quite short and simple, hopefully, so I'll fire both at you in one hit. The targets that we've seen quite a few targets there. Are they just national targets, or are they kind of localised at all? And I wondered if you have any opinion on, if they are national, what being a predominantly rural area, what impact does that have on us? Are we kind of dealt a raw hand? The next question was regarding the metrics. Do you have a metric, or are you monitoring incidents whereby the see and treat may not have been required and hear and treat would have been a better option? I just wondered how you're monitoring the effectiveness of that service.
Thank you for that. So the targets are a nationally based target. So for our category 1, category 2, there is a nationally set target. However, our lead commissioner for our region has set us an expanded target for that category 2. So it's 18 minutes is the national target set by the government. The commissioners have identified that with the pressure and the demand that we're under, we're not going to achieve that from a commissioning basis. So they've set a target of 30 minutes for us. That's for this year alone. So in April, we will go back to that review and may go back down to the 18 minutes. I'll let you come in.
Sorry, Martin, to jump in. On that 30 minutes, that is a national target as well.
Yes.
It's not just for East Midlands Ambulance Service, that's for the whole of England this year.
You asked about rural impact. Absolutely, some of our very rural areas will be impacted by the distance that they live from our responding area. We do everything we can to spread out the resources we've got. So we have, obviously, as Mick has said, we've got 8 stations across the county. We predominantly place, they're placed in the larger towns across the county. We will, when we have vehicles available, move them into what we call standby points. So there'll be positions between those major towns to try and spread that resource and put them closer. However, the very rural places, it will always be difficult to get to them within that target because of the road networks across the county. But that's why we have the number of fast response vehicles, because they physically can get somewhere just a little quicker. The other thing that I would say that we have tried to look at, and we've done very well in Northamptonshire, is around our community responders. Sorry, I've beat.
Just give you a nudge then.
Our community responders. So we've got a number of schemes across the county with volunteers who are community-based. They're trained by EMAS. They are able to go out and give that initial set of care within some of those very rural settings. I would say Corby here has a very active scheme. There's others around the county. And that helps us reach those rural areas because they're already in that. The other thing that's helped for the very serious patients, the cardiac arrest, is an absolute push, and you will have all have seen this, around community defibs. Primarily now you can't find a telephone box that's got a telephone in it. It's either got a book library or a defib in it, which is brilliant, and they're registered with our control centre so that we can direct people to those. Your other question was around see and treat and whether that should have been hear and treat. And vice versa, yeah. The hear and treat, we do monitor the number of recalls. So if they call us and then recall us, we do monitor that. And that's a very low percentage. Now, patients' conditions can always change. So that is always one of our sort of backup sort of advice, that if anything changes, call us back. From a see and treat where we've gone out to patients where we shouldn't, that we have got a process around an inappropriate sort of triaging process, so the staff can report that, and then we can review what happened with that triage, what information was given, and was that what ended up with a response, and whether that needs some further education, etc., for the clinician. But again, very rare, because we've got some very experienced clinicians, and a lot of them have come from off the road, from a responding ambulance background into that control clinician background, and they've got that sort of knowledge base to safely know when to send an ambulance and when not to.
Thank you. Councillor Lee.
Thank you. How can councillors access any outcome of harm reviews, numbers and so on? Are they not publicly available? Because that's a good finger on the pulse of the result, really, the effect, the impact of hospitals not being able to process sufficient patients. And it's not really the hospital's fault, but just for us to realise how bad the situation is.
Yeah. I think that information can be found on our website and our quality account for the Trust. Yeah.
Thank you. Councillor Lorman.
Thank you. Obviously, Northamptonshire sits right on the edge of your area, and with some significant population centres further north. And there's always been a perception that we're a bit on the edge, and that vehicles got displaced from us because there were lots of calls in Leicester and Nottingham and Derby and wherever else, and we're running short. So perhaps you could comment on whether that still happens. The second thing, you mentioned you have between 17 and 42 units out there. I just wonder whether that was because it's quite a difference, because 17 doesn't seem like very many to cover the whole of your area. And I don't wonder whether that was just by design, because you knew when there was a lower expected demand, and so that was by not just because people weren't turning up or vehicles weren't under it. I also noticed on the first slide you had 21 freedom to speak up requests, and I wondered if you were able to give any more detail about what sort of things you were finding there. And the last one, have you got any electric vehicles yet? Because it's one of the things.
Right, I'll do two, you can do two. All right, so going from the bottom upwards, yes, we have got some electric vehicles. Mainly in Derbyshire, all their PTS fleet now is totally electric. We are just trialling, we've got one or two, isn't it?
We've got one currently. Apologies, we've got one electric fast response vehicle. We've put some of that infrastructure in behind that. So we put chargers in 3 of our stations, I think then, to allow the recharge of that vehicle in a timely manner. Obviously, we've gone for vehicles with a reasonable range. We then need to get a vehicle that we can charge reasonably quickly. So yeah, the other thing I would say is that obviously we have there is plans to move to electric vehicles across the whole fleet. What we have done is our support services, so our logistics drivers, our fleet drivers, they are on electric vehicles already. So where we can facilitate it, we have.
So going on to your next question, your freedom to speak up. Yeah, we do have freedom to speak up, and we're quite open and transparent, especially more so, well, not more so in Northamptonshire. And, you know, they mainly are probably internal issues with the members of staff who agree with one thing or another. And I've got a view of, I'd rather come and talk to you. Come and talk to me face to face, see what the problem is, because there's nothing we can't sort out. So, yeah, probably more employee relations sort of issues, really, that really are the freedom to speak up issues.
So I'll pick up the vehicle numbers. Yeah, there is a big difference between the 17 and 42. 17 is, if you like, where the lowest. So that'll be sort of during the night time, after around 2 o'clock in the morning. That's where we naturally see our demand dip off. So that's where it'll drop to that 17. And then as we come into the daytime, we'll have a staggered start to where our vehicles start, and that's where it rises all the way to 42. So by about 2 o'clock in the afternoon, that's where we're sitting at that sort of 42, with the additional resources that we're also adding into that. And the last point is what we refer to as drift. So drift is where our vehicles will potentially go into another county, or vice versa. This is monitored by all counties across the region because we're very possessive about our vehicles and where they work, and for the right reasons. We've actually seen a reduction in drift for our vehicles going elsewhere. A lot of that's actually around some of our closest neighbour, which is Leicestershire. Some of the acute issues that they were experiencing have diminished quite dramatically. I'm not saying it's sorted altogether because we've come into winter and it's come back a little bit, but that's absolutely helped reduce the need for us to go and support other areas. Now, we will still do it, especially if there's a patient with an immediate need. We'll absolutely send the nearest vehicle, and vice versa. So what we do actually find is those patients from, say, the Market Harbour area, where their natural catchment acute is Kettering, those vehicles will bring that patient from Market Harbour into Kettering General, and then when they book clear, if they're the next available vehicle for a job in this area, they'll be used. So we do get a little bit of movement both ways, and it's a lot fairer than it used to be.
Thank you. Thank you very much, and thank you for your presentation and answering questions. Any colleagues have any further questions? Yes.
It's more of a comment, really. Really interesting presentation, really amazing work going on, which is fantastic. And I really applaud your ambitions around health inequalities and reducing that through the work that you do. And I guess it's more of an offer about, are we really optimising our cross-working with public health and with yourselves? And perhaps outside of this meeting, we can have discussions, because your staff are so trusted by people that it's an amazing opportunity. So if we can link up, that would be great.
Absolutely, and then that's what I was hoping an outcome of tonight would be. So yeah, thank you.
Wonderful, thank you. I think that concludes this item. Thank you very much. Yeah. Moving on to item, are we going back to 6, the update on Kettering General Hospital? Yes.
Thank you. So thank you very much for inviting me today. I'm here to give an update on the new hospital programme at Kettering Hospital. Could you flick on to the next slide, please? Okay, so I've only got a few slides, but a little bit of background in case any councillors weren't here at the time, or just as a reminder. So Kettering Hospital, KGH, was announced in October 2019 for 2 different funding pots from NHSE and from Department of Health. First of which was what we had asked for, which was £49 million for a new A&E department. But we were also at the same time announced as being one of the 40 new hospitals across the UK, and were provisionally allocated 350 million to come up with a plan as to what that meant and what we were going to do. So we spent really most of 2020, we started from scratch to say, well, how could we use that money? How could we rebuild Kettering Hospital? And we looked at a variety of options, which did include a greenfield site that was identified as being up on the A14. That got discounted at the time because it was so much more money than we had provisionally been allocated. It would have been over £1 billion that we thought, actually, we'll just get stuck with not getting anything approved. So we needed, and we also managed to prove at that point that we could rebuild Kettering Hospital on the current hospital site while still safely running a hospital. That was going to cost somewhere nearer the amount of money we'd been provisionally allocated. So that was our preferred option that our board approved, and I think I updated a previous committee around about that time, this committee, on that decision. We then, that was part of a strategic outline case. Apologies for the abbreviations on these. So we then undertook an outline business case, that's the OBC abbreviation on there, that basically settled on 2 buildings on the current hospital site, 2 6-storey buildings, and I'll come on to a bit of the detail around that in just a moment. But that was really welcomed, I think, as a very sensible, positive scheme by NHS England. Principally, for the reasons set out there, we didn't need to get involved with buying new land and land acquisitions and planning permissions and putting in new highways and new infrastructure and electrical works and all of that kind of thing, which made it a lot simpler and a lot easier. Because we weren't planning on moving clinical services around, we didn't need to do any public consultation in terms of that. And again, when you look at some of the other 40 schemes across the UK that were actually ahead of us at Kettering initially, they've actually slowed right down and we've sped up because they've been stuck in public consultation for quite some time. So that's been welcomed, and I won't read through the others. It's been welcomed by ministers. We've had quite a few Secretary of State visits. Our local MPs are very supportive to say, and as are NHS England, to say it's actually a scheme that's fairly simple, won't get stuck in the mire, and can progress fairly well. So we've actually moved from being right at the back of the 40 new hospitals without any plans at all to actually being really quite near the front of the 40 hospitals. So it's been a really positive couple of years. I think the key one is the bullet point at the bottom there. So the energy infrastructure at Kettering Hospital is very high risk. For those of you that have been onto certainly the bottom of the site, you would have seen 2 big blue temporary boilers. So we have been reliant on temporary boilers for a number of years. And the steam infrastructure, so we heat all of our buildings through a steam infrastructure system that's over 50 years old, regularly breaks down. We don't have any maintenance contracts. There are no companies that provide maintenance contracts for that anymore. So it's quite long periods of time that some of our wards are without hot water and without heating while we fix some of that infrastructure. So we identified that actually replacing that infrastructure and that energy centre was a key enabler to enable us to actually build the buildings. Principally, we can't actually we are over our electrical bandwidth in terms of the pipe that we get in from the national grid. So we can't actually start building anything because we can't use any more electricity on the site until we've upgraded some of that work. So we did submit a separate business case that was for £38 million for that in October 22, and that has been approved. So they have provisionally allocated the money for us. We do need to complete a full business case, and I'll come back to that in a moment. Next slide, please. So this is a diagram of what the work's going to look like. So just to orientate you, the top of each of those pictures is the Rothwell Road. So top left is the main roundabout where you come down from the A14, down the Rothwell Road, and then top right is down at the bottom of the hill where the railway bridge is. So top left picture as a whole is our current how our current buildings are built around the site. You can see it's a bit of a hot-potch, higgledy-piggledy way, and I'm sure for those of you that use the buildings, there are lots of different alleyways and buildings that connect in, and it's quite hard to find your way around. That is completely typical of most NHS hospitals because funding has been allocated over history just in small pots, so you end up building separate small buildings. Second picture along there, you can see outlined in blue is our first piece of work. Again, I'll come on to that just in a moment, which is demolishing that series of buildings. Most of the services in those buildings are corporate office space. So where our headquarters are, where our HR and finance departments are, and that kind of thing. There is one building where Warren Hill House where some clinical services are provided out of there. For patients, that affects anti-coag and pain services. And I'll come on to that in a moment. So moving across to phase 1, you can see where we've demolished those blue buildings, that H kind of a building, that's the first 6-storey the building that we'll be building. That is, if people know the site, that is on car park A. So that is our first building. We will then be able to move services into that and then demolish the next series of buildings. And you can see bottom left there is phase 2, which is the second 6-storey building. And then that ties into doing some wider site master planning and making the site look a bit nicer and making access better onto the site, which is kind of where we'll stop. We do have longer term plans for, again, being able to demolish the rest of some of those old buildings. But those 2 buildings alone get us to replace about over 70% of our inpatient ward stock would be replaced. And obviously we're concentrating on our really old inpatient wards that currently aren't really fit for use. So if Karen to the next slide, please, and I'll give a summary of what was originally planned to be in those buildings. So that first building will be replacing our A&E department. It will be replacing then our short stay wards, so where patients are in A&E and there's a decision where we need to care for you longer, we need to move you into a short stay ward or indeed move you into some medical wards. Those buildings will all be in those services, will all be in that first building. So it will hopefully keep patients and our staff focused in one area, which brings staffing efficiencies as well as less movement for patients around. Then the second phase will allow us to build a new main entrance into the hospital, which will be facing the Rothwell Road, so it'll be much easier for patients and visitors to use public transport and buses that are on the Rothwell Road and then access directly into the main entrance rather than have to go to the back of the site. At the time, and I'll come back to this, we also then planned in that second building an endoscopy unit and more of kind of a planned care, so elective theatres, surgical wards, new critical care unit, that kind of thing would be in those buildings. Next slide, please. And that is an artist's impression of what it would look like from the Rothwell Road. So we are on a slope, as you know, the hospital, so there are slightly different angles, hence why we need to have built the second building to create that new main entrance. But the building on the right there is where you'll have A&E on the ground floor and those medical wards above. And on the left is the new diagnostics and theatres and planned care wards. Next slide, please. Okay, so where are we now? A bit of an update. So in terms of the energy infrastructure that I was talking about, we have, since that approval back in October, we have appointed now a construction partner. So they will build, it's now gone up to £49 million, principally because of inflation. People will know about the construction market inflation and how massive that's been. So that's now at 49 million, but NHS England is still supportive, absolutely, of us doing that. So we've got a construction partner in place and we've done further designs. So work will start on that in February. This year, end of February, and that initial work is on that electrical infrastructure. So we'll be digging up trenches at the bottom of the hill to bring in more electrical intake onto the site, create a new electrical substation. It's all very technical and certainly not in my area of expertise, but that's the key first work that we need to be doing. I'll come on to the impact of what that means for our patients and our staff. But that will start, and that will then be followed up by a brand new energy centre at the bottom part of the site. That will also improve our net zero carbon by 58% when that's open. So it's going to be a huge improvement. There'll be air source heat pumps and solar panels and all sorts of things across the site to help support that. That will start, the work on that will start in beginning of 2025 and will complete in 2026. So by 2026, we will have that new energy centre running the whole of the site. and the risk to collapsing and heating and all that kind of thing will significantly improve at that point. There are some other enablers that I've kind of referenced. So we will be building a multi-storey car park. We're just working on plans. That will be at the bottom end of the site as well, because obviously I've just told you earlier that that first building will be on a car park at the top of the site. So we know we need to build new car parking facilities before we can get rid of that car park at the top. So we are going to be building that work and planning on that with NHS England has already started. I've told you about we'll be demolishing some of the buildings, so of course we need to find space for where our office staff are going to be working and for that pain service and the anti-coag. We think we've done that, but we're just working through some of the plans on that, and we need to demolish some of those things. So in terms of the main scheme, so all of the 40 new hospitals are still in discussions with the new hospital programme nationally as to timeframes. The manifesto commitment is that the funding that's been provisionally allocated, which nationally is 20 billion, will be available between 2025 and 2030. To be honest, there is some concern that 40 hospitals could not possibly get built in a 5-year period across the whole of the country. But nevertheless, that's a thing that we're working through. All the 40 hospitals are working through with NHS England and the Department of Health, and of course our political parties. But they are working very closely with us. So we are currently undertaking some demand and capacity modelling with them, with the national team. That will tell us, we think we know how many beds Kettering Hospital needs for the next 30 years. But of course, across the 40 hospitals, everybody has used slightly different assumptions on what they think and what out-of-hospital care needs to look like. So there is a national approach for that. So we are starting that at the end of February. That's with all of our ICB colleagues. So we should, as a result of that, say how many beds Kettering Hospital needs for the future and what we should be planning for, but also what does the capacity need to look like in community care and in social care. So that will be an aligned ICB approach into how we do that. They have already come and assessed us for our organisational readiness and how well we are set up to build the new hospital. That's been a very positive experience. They're happy that we've got the right people and the right skills and the right resources in place to progress with the building. We are going to need to do some clinical reprioritisation of what is in the second building. I kind of slightly mentioned that. That's because we decided that a couple of years ago, and times have changed since then. So since then, for example, we've had community diagnostic centres approved, and we'll be building one in Corby and one in Northampton. So we don't need the same amount of imaging capacity on the hospital site. Another example, and we certainly don't need the same amount of endoscopy capacity. There is a new county mortuary that's hopefully going to be built, and there are plans that are getting discussed for that. So again, we've been working with the two unitaries to say, well, actually, do we really need the same amount of mortuary space on the two hospital sites, and how can we work much better together on some of those things? So we need to finalise some of those conversations over the next 3 months to reconfirm what is going to be in that second building. I probably should mention as well, because it has been in the public press, that we have found some rack concrete, some aerated concrete in our Rockingham building. So we are just doing the structural surveys on that currently. Depending on what that says, we might need to consider, do we need to put women's and children's services into that second building instead, for example. So there's some further work that we need to do on that 2 years later. There's also some work, aside from on some of the projects, and don't worry, I will stop talking in just a moment, on what some of our interim car parking and wayfinding around the site is. So when we start digging up the trenches at the end of February, we will be losing car parking space down at the bottom of the site. And obviously we want to make sure that our staff, that our visitors and our patients have access to the right amount of car parking on the site. So we are going to be doing things with our staff to move some of our staff car parking off-site to make sure that our patients and visitors have access. But also, very well aware, when we've got building work going on a hospital site, we need to be really clear on wayfinding and signage, so that it's already complicated enough to work your way around any hospital, but let alone for our staff, but let alone, you know, when there's interim building work going on. So we are going to be doing a lot more of that, and we'll be engaging with our governors and with our patients and with some of our groups to make sure that that's as clear as it possibly can be over the coming weeks. But in terms of the main scheme, because of all of that work we need to do first, if we were going to get the go-ahead today, we're envisaging we would probably start with diggers in the ground around 2026. I think there might be one. Is there one more slide? Well, I won't. This will come around in your packs because it's ever so difficult to see. But this gives you a bit of a timeline as to when you can start to see some of the works and some of the enabling works. I'll make sure that gets circulated to committee members, and I'm happy to take any questions once you've had a chance to get into the detail of looking at that, if there are any. And I believe that's my final slide, isn't it? Oh, no, it's not. Okay, so this is a bit of an old diagram, but I thought I'd pop it in there. So you can see there the Rothwell Road. So once we have built our new buildings, there will be new access routes onto the site. Currently, people will know there's a couple of different access routes. They're not the easiest. There's quite a lot of congestion on the Rothwell Road, particularly at times where our staff start shifts and end shifts. Getting on and off site can be difficult, and there can be quite a lot of traffic congestion. So we are working with the planning team, and have been for some time, on improving that access. So there'll be much clearer routes and bus transport routes into the site and up close to the buildings to enable much easier access to people that are using public transport as well. Thank you.
No, thank you. And I think that's wonderfully insightful and comprehensive. And you answered a lot of questions that I had in that presentation. I wanted to again probe you on the surety that you have during the redevelopment, and I've read your development control plan as well, which was approved by your board in 2020. How confident are you that we're not going to be losing any operational effectiveness during your redevelopment phases?
Yeah, I mean, it's absolutely essential. So it's key part of our planning will be making sure that we can still operationally run the hospital, and we have tested that, so we won't be, aside from those very small number of services that I've just talked about, and we hopefully now have a plan that will re-provide that, we will be building new services. We won't be touching the rest of the buildings that are operational until that building is ready to be open, and then we will move services in. And I come from my career at previous hospitals I've worked at. I was part of the move programme between Peterborough Old Hospital, Peterborough New Hospital, and we were able to move into a brand new hospital, the entirety of it, overnight with no impact whatsoever on operational performance or services to patients. So I would have the expectation we would do exactly the same.
Thank you. Do colleagues have any questions? No, that's great. Yeah, Councillor Lee.
I just wanted to thank you. That's a really, really insightful presentation. It would be good if we can devise a system for future meetings that if we don't get these slides in advance, that the screen can be shared so that we can watch it back afterwards together with you talking. I didn't catch your name, I'm sorry. But
Polly, my apologies, Polly Grimmett.
Thank you so much. No. Oh, sorry, it's in the papers. Thank you very much. That's been
more than welcome.
Very interesting. Thank you.
Good, thank you.
Thank you. Any further questions for Polly? Yeah. Thank you very much. Thank you, Polly, for that. Brilliant. I'm sure we'll have you back for future updates. That concludes the items. We've got the work health scrutiny work plan. We've got it's in front of us here. It should be on your papers, but I think the majority is discussed at the Scrutiny Management Board. But thank you. Yeah.
Sorry, Chair. Adele did ask if I could just take us through this, if that's okay.
Take us through.
Yes,
of course. So please, yes, David.
Scrutiny work plan.
Yeah. Thank you.
So we were due to have pre-scrutiny of an executive report today, so we had been intending to take an item on the adult social care strategic framework to the executive on the 18th of January. However, on discussion with Democratic Services, it was felt that it was too early in their stage to do that, so we're just in an engagement stage on that strategy. So it will remain on the work plan, but will be brought back for a later meeting. current items that we have for the 12th of March. So we've got GP performance and availability. Then we have the NHS Northamptonshire ICB 5-year joint forward plan, and then an item on substance abuse strategies. I think there was also a pre-scrutiny of executive report as well, potentially coming to that meeting around a homelessness and rough sleeping strategy. I think it may be a little bit early for that, but we will confirm closer to the time. And then finally, just for May, at this moment in time, we only have the annual report for NHFT on the agenda currently, so there is space at the March and May meetings for other items at this moment in time that you can recommend through to Scrutiny Management Board, who will then agree which items can come forward. What I would ask is if any of those items include external partners, so for example EMAS or the General Hospital, NHFT, or for example, primary care, we need a bit of time to organise the external contributors like Polly and Mark and colleagues tonight. But happy to take any questions, or if there are any areas that you wanted to explore with me around potential items, I'm happy to try and field those questions for you.
Does colleagues have any questions on this point? I think we'll... please, Councillor Lorman.
I'm going to suggest something. I wonder whether it would be worth looking at the Corby Diagnostic Centre. And it's a separate unit, and there have been some issues in the provision there, and some investment as well. So it may well be worth getting a look at that.
Okay. I mean, certainly, if you could perhaps discuss offline, perhaps the key lines of inquiry that you would want anyone to come and talk to, then we can speak to partners, and we can make sure that any presentation or report is appropriate in that sense. It's definitely the diagnostic centre, not the walk-in centre. Okay, thank you.
I think we'll pick up a lot of the other points of discussion at the Scrutiny Management Board, unless colleagues have any further points for David. No. Thank you very much. Thank you.
Chairman, we've missed out item 10, I think.
Have we missed item 10? Yes, we did item 10. That's short breaks. We did that earlier.
Item 10 was the first item covered.
Yes.
I'm always concerned about support for new mothers, new parents, breastfeeding and so on. Maybe all that is going really, really well, but I would be interested in a report about that, because we may have a shortage of health visitors and so on, and midwives. So I would really welcome that. Thank you very much.
Yes, please.
Can I suggest perhaps, Councillor Lee, that we look at bringing that broader early years work to this, to our health visiting, our Strong Start, and it's really timely as well because that we're moving into a recommissioning cycle.
It's a very important topic. Thank you, Councillor Lee. Any further points to raise on this? No, I think we have covered off item 10 in a lot of details, Councillor Lorman. Right. Thank you very much. I close the meeting. Thank you. Cheers.